Today, I'll talk about hyperkalemia. This is a critically important topic both in clinical practice and on exams. Because hyperkalemia is a true medical emergency, elevated potassium level can trigger life-threatening arrhythmias. And once hyperkalemia is identified, you must act quickly. However, for many students and residents, hyperkalemia feels confusing and intimidating, making it one of those conditions they hope they never encounter. In this video, I'll explain hyperkalemia using a simple schematic approach so that by the end, you'll be able to stay calm and act fast when facing a patient with hyperkalemia. To understand hyperkalemia, the first key concept is potassium distribution in the body. Most potassium is located inside cells rather than in bloodstream. As a result, hyperkalemia using develops either when potassium seeps out of cells or when the kidneys fail to excrete it adequately. One major mechanism is cell destruction. When cells are damaged or rise, potassium is released into the bloodstream. This occurs in conditions such as rhabdomyolysis, tumor lysis syndrome, severe trauma, or extensive burns. Because intercellular potassium concentration is high, even limited cell injury can cause a rapid increase in serum potassium level. Another important mechanism is impaired potassium shift into cells. Under normal circumstances, insulin promotes potassium entry into cell with glucose. When insulin is deficient or ineffective, potassium remains in the extracellular space and accumulates in the blood. This explains why hyperkalemia is commonly seen in diabetic ketoacidosis or in patients with severe insulin deficiency such as those with type 1 diabetes. The third major mechanism is reduced renal excretion. The kidneys are essential for potassium homeostasis. In the collecting duct, aldosterone enhances sodium reabsorption while promoting potassium excretion into the urine. When aldosterone activity is reduced or when renal function itself is impaired, potassium excretion decreases. This is why hyperkalemia is frequently associated with chronic kidney disease, acute kidney injury, and medication that interfere with renin-angiotensin-aldosterone system. As potassium level rise, the most dangerous consequences occur in the heart. Elevated potassium reduces the rest membrane potential, making cardiac cells electrically unstable. That's why hyperkalemia can rapidly progress to fatal arrhythmias. For this reason, whenever hyperkalemia is suspected, an ECG must be evaluated immediately. The most characteristic ECG finding is tall peaked T wave, as hyperkalemia worsens PR prolongation, QRS widening, and eventually sinus wave pattern, ventricular arrhythmia, or cardiac arrest may occur. These ECG changes signal imminent danger and require urgent intervention. It is also important to recognize pseudo-hyperkalemia. Sometimes potassium appears elevated due to hemolysis during blood sampling rather than the true hyperkalemia. However, this distinction should never delay treatment when ECG abnormalities are present. In clinical practice, hyperkalemia should be treated as an emergency when serum potassium is around 6 mg per liter or higher, when ECG changes are present, or when potassium levels are rising rapidly, such as in acute kidney injury or tumor lysis syndrome. Once the mechanisms are understood, treatment becomes much more logical. The management of hyperkalemia follows three fundamental goals: stabilization the heart, shifting potassium into cells, and removing potassium from the body. Cardiac stabilization is achieved with calcium gluconate. Calcium does not lower potassium level, but it stabilizes myocardial cell membrane and reduce the risk of fatal arrhythmias. This effect is rapid and life-saving, particularly in patients with ECG changes. The next step is shifting potassium into cells. This is most commonly accomplished with insulin administered together with glucose. Insulin drives potassium into cells, while glucose prevents hypoglycemia. In addition, beta-adrenergic agonists can also promote intercellular potassium shift by stimulating cellular uptake. These agents can be helpful as adjunctive therapy, although they are not always sufficient alone. In contrast, beta blocker may impair this potassium shift and can worsen hyperkalemia. so medication history should always be reviewed carefully. Finally, potassium must be removed from the body. If the kidney function allows, loop diuretic can increase urinary potassium excretion. Potassium binding ion exchange resin can also remove potassium through gastrointestinal tract. However, their onset of action is slow, so they should be considered adjunctive therapy rather than emergency treatment when renal function is severely impaired or when hyperkalemia is refractory or life-threatening. Dialysis remains the most definitive and effective method for potassium removal. Of course, identifying and discontinuing offending medication is also essential, as many commonly used drugs can contribute to hyperkalemia. In summary, hyperkalemia develops through three main mechanisms: potassium release from the body, potassium release from damaged cell, impaired potassium shift into cells, and reduced renal excretion. Its danger lies in its profound effect on cardiac conduction. Treatment follows three essential steps: protect the heart, shift potassium into cells, and remove potassium from the body. If you understand this framework and can reproduce it by yourself, hyperkalemia will no longer feel overwhelming. You will be able to stay calm, act fast, and protect your patient when it matters most. Good luck, and I'll see you in the next lesson.